bone fracture concurrent with the complex forearm fracture and dislocation, which we call the Gallagher fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture of a 17-year-old gentleman, and the forearm Gallagher fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Gallagher fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Gallagher fracture. And this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Gallagher fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the Gallagher fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures, because the narrow canal and the length should be maintained to, and DR, UJ should be reduced properly. We followed the throughout the 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes this approach should be considered for Galerie fracture in adult after further studies, because I think this is the first case in severe Galerie fracture. I did 10. So this case was published in International Journal of Orthopedic Sciences. The statistical teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense nailing or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense nailing. Unlike preservative management, it provides stable fixation and early mobilization and reduce the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nailing in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out-stretched hand was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI, and this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin, and this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of condition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and the screw. So these are already explained. The simple fracture were taken into consideration. Displaced simple fractures are spiral or oblique or transverse or short oblique, 15D1 and D2. The patient lies supine on a affected lip, elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed wing. The incision, a small incision, and a transverse or longitudinal incision about 1 to 1.5 centimeters, just lateral to the sternoclavicular joint is given. And after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense nailing after close reduction or mini incision reduction. So the immediate course of pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, at 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, where 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite out, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nailing, beautiful surgery without use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, and yet another case of the by titanium elastic nailing. Yet another case of 15B1 fracture treated by titanium elastic nailing. These are the 15B2 fracture. This is 15B3 fracture treated by titanium elastic nailing. Ideally, it should be treated by open reduction and internal fixation, but we did tense nailing, and you can see that 6-month follow-up. The beautiful radiological union. This is the functional result. You can see. So the time is there. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of distress fracture. The take-home message is tense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further studies are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science.
छपरा के डॉक्टर आरसी ठाकुर ने हड्डी फ्रैक्चर के इलाज में क्रांतिकारी तकनीक विकसित कर देश भर में पहचान बनाई है। उनकी तकनीक से 35 लाख रुपए तक का महंगा इलाज मात्र 35,000 में संभव हो सका है। ऑर्थो सर्जरी में योगदान के लिए गुवाहाटी में आयोजित इंडियन ऑर्थोपेडिक एसोसिएशन के राष्ट्रीय सम्मेलन में उन्हें इनोवेशन अवार्ड से सम्मानित किया गया। यह उपलब्धि छपरा, सारण और बिहार के लिए गर्व की बात है।
इनोवेशन अवार्ड इंडियन ऑर्थोपेडिक एसोसिएशन द्वारा शुरू किया गया है, जो कि गुवाहाटी IOA 25 में दिया गया है। और यह अवार्ड पूरा भारतवर्ष में 3 ऑर्थोपेडिक सर्जन को मिला है, जिसमें बिहार से मेरा ही नाम है। अतः इससे छपरा जिला में जिला का कोई ऑर्थोपेडिक सर्जन या बिहार का कोई ऑर्थोपेडिक सर्जन को पहले बार सौभाग्य प्राप्त हुआ है, जिसमें मेरा नाम आया है। Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected eject entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture, and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the every view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we removed this bone out, and then after reduction of the fracture, with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ream the medullary canal with the help of 9 millimeter ream, and it is being reamed with 9 millimeter ream, hand ream. And it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the learning process with the help of the F tool. During reaming process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. doing reading with a 10 millimeter rework, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in amplitude, and also in lateral view. This is the oblique view. And after performing in the CR, in both views, we did reading up to the lower end of the femur, and finally we removed this fracture with the help of power removal 11 millimeter. Because the patient is old one, so reading is easy. It is just to measure the size of the intramedullary canal, the diameter of the intramedullary canal, so what size of the nail should be introduced so that it can fit in the intramedullary canal, the fitting nail can be introduced. So this is the purpose of reading. Because the patient is old-born osteoporotic, throughout the nailing process, reading process and nailing process, the fracture is kept in reduced position by my assistant. And the fracture has been linked up to the lower upper end of the patella, as you can see in the CR picture. You can see in the CR picture. It is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, 11 millimeter nail on cheek. And finally I am hammering the nail inside the intramedullary canal and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented. And finally, I have introduced the appropriate size nail up to the upper pole of the patella. Good position, the fracture is reduced in both view, in the oblique view and lefty view, and lateral view. And then I will remove the guide wire before proximal locking. And now I am doing proximal locking after removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. And I am doing proximal locking. The proximal hole in the proximal fragment the near cortex is perforated with the help of 2.5 millimeter K wire, and the distant cortex is drilled with 3.2 millimeter drill bit, and finally we select a proper size 5 millimeter screw for proximal locking, and I am still making a hole in the distal fragment, distal cortex, and now I am tightening the screw, the second screw in the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position, and it is confirmed that it is inside the hole in both AP and lateral view. And now I will do the distal locking by freehand technique. I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with 3.2 millimeter drill bit. As you can see in this picture, and both the screws has been tightened and confirmed in AP and lateral view. The size of the screw is confirmed in the AP view, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted.
Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Chhapra, Bihar. Today I am going to present my innovative tibial nail extractor can be used to introduce the nail in proper position. Between March 2020 to March 2021, Dr. Thakur innovative technique of suprapatellar nailing of tibia conducted on 25 patients to fix their tibial fractures. Inserted. Entry point is just medial to the lateral tibial spine. The guide wire, first malleable guide wire, we are introduced after severe bleeding, fracture reduction, and confirmed by fluoroscopy, mounting of the nail with appropriate size over the color-coded tibial nail extractor done. Introduction of appropriate nail size over the guide wire done in proper position with the help of color-coded tibial nail extractor. Locking both proximal and distal done by freehand technique. No jig were used. Wash and repair of quadriceps tendon done and closure done. These are the pictures how we did our cases by Dr. Thakur innovative technique. These are the instruments, the color-coded tibial nail extractor, protective sleeve from PF and A2 set, trocar and malleable guide wire, and stout and hard guide wire. Reamer, these are the passage of sleeve, trocar and hard guide wire in the retropatellar space in AP and lateral view. Passage of reamer over the guide wire after percutaneous reduction with the reduction forceps in AP view, and this is in lateral view. Nail entry over the guide wire and nail entry in distal fragment in AP view. Nail entry in distal fragment in lateral view, and then both locking screw introduced in proximal fragment. In AP and lateral view, all the three screws introduced in distal fragment by freehand technique. This is the clinical picture. Proximal locking done by freehand technique. Post-operative follow-up steps. First post-operative day, passive flexion and extension of the knee and ankle joint done. Third post-operative day, active flexion and extension at the knee joint and ankle joint done. 10th post-operative day, patient started walking with the help of walker, non-weight bearing. 6 to 8 weeks post-op, we started partial weight bearing. 12 weeks after operation, we started full weight bearing. Now, the final observation, operative time was in this study 80 plus minus 10 minutes. Range was 65 to 110 minutes. Average fluoroscopy during surgery was 38.5 plus minus 6.5 seconds. The range being 10 to 50 seconds. The average time of funial fracture was 8 weeks after surgery, with fracture healing time was 12 weeks. Average hospital stay was 10 to 12 days. All patients followed up after 2, 3, 6 and 12 weeks. Those who could not return for follow-up, telephonic follow-ups were done and called for follow-up in hospital. No complication were observed. No patient experienced any loosening or breakage of a screw or nail. No one complained of knee pain. No reduction loss or significant displacement of fracture occurred after surgery. At final follow-up, 21 cases found excellent and 4 good results. Comparative with the standard technique, the status of cartilage over the patella and trochlea post-surgery has not been evaluated. Thus, furthermore study with larger observation and long follow-up time is required to compare this innovative technique with a standard technique of suprapatellar nailing. In this technique, fluoroscopy time was slightly more than the standard technique because both distal and proximal locking were done by freehand technique. Finally,